Hello and welcome to North Shore Private's virtual GP education program. This session, I Hear You, Cochlear Implants, the Patient's Journey, was recorded at a live session in February 2023. Presenters on the night were Associate Professor Nirmal Patel, ENT Specialist, Associate Professor Nicholas Jufus, ENT Specialist, Audiologist Annette Smith and James Leask, and cochlear implant patients. Use QuickLog to gain CPD hours for this session.
Thank you. My name is Annette Smith. I'm an audiologist from Northside Audiology. My colleague James Leask is here tonight. We're sharing this first session and then we're going to pass over to Nicholas and Nirmal. We're going to start off talking about assessing candidacy with cochlear implants. But before I do that, I think it's important that we acknowledge the traditional custodians of the lands on which we meet tonight, both here and for those of you watching on Zoom where you are, and we pay respect to elders past and present. James and I live and work on Darug land, and it would be remiss of me at this point not to also acknowledge the significantly higher rates of ear disease and hearing loss in Aboriginal and Torres Strait Islanders, and to recognise that there's still a long way to go in closing the gap in hearing care and outcomes for this population. Some background. I mentioned James and myself. We're working for Northside Audiology. We are based at Bella Vista. We also have a clinic at Chatswood, and we visit at Newcastle Bay and Wadesville. Our directors include 3 ear, nose and throat specialists, Dr. Martin Clara, Professor Nirmal Patel, and Clinical Associate Professor Nicholas Jufus. And we work with Nirmal and Nicholas on the implant program. And they're going to be presenting tonight as well. We work with adults in diagnostic and rehabilitative audiology, including hearing aid fitting and cochlear implants. So we are able to work holistically with the clients, with both the hearing aid and the cochlear implant. But we also have a number of clients who have a long-term relationship with another hearing aid. And we're happy to support those patients with their cochlear implant whilst they still get services for their hearing aids elsewhere. We're happy to work as part of the team. We would like to acknowledge Cochlear's sponsorship of tonight's program, and we have made use of some of the resources in our presentation tonight. But as being part of an independent clinic, we do also work with other manufacturers. So the objectives tonight, I hope you've read this on the flyer, and that's why you decided to come along and join this session tonight, to look at the assessment criteria for cochlear implant candidacy and outline the treatment pathway with some of the cochlear implant. And really that boils down to the why, the who, the when, the where, and the how to refer. What's actually involved in a candidacy assessment? So if you refer someone to us to talk about cochlear implantation, what are you actually referring for? And then we'll be talking a little bit about beyond the initial referral, the surgery, the rehab, and the outcomes. And the way that we're going to do that is starting off with us with an audiological perspective. Nirmal's going to hopefully show some videos about cochlear implant surgery itself. Nicholas is going to share some of the important things to know before and after implantation. And then the part that I'm really looking forward to the most is we have 4 cochlear implant recipients who've come along tonight to share their experience and their journey to cochlear implantation. So we look forward to hearing from those surviving their stage 21. Before we get into the more technical, theoretical bits of this, I'd like to just start with a quote from Helen Keller. It's something that drives why I do what I do. Helen Keller, if you don't know, was an American author, disability rights advocate, and political activist and lecturer. She was born in 1880, and at 18 months of age, she lost her sight and her hearing due to illness. But with the support of her teacher, Anne Sullivan, she learned to sign, to read Braille, and to speak. And Helen Keller is attributed with saying, when you lose your eyesight, you lose contact with things. When you lose your hearing, you lose contact with people. And that's what we're here for tonight. We don't want people losing contact with people. Hearing is about how we communicate and keep in touch with the people in the world around us. And that's why it's so important that we're looking at ways of improving things. So, what is your experience of cochlear implants? Now, I know we have a couple of cochlear implant recipients here, but does anyone else in our group here tonight, they have a cochlear implant, care to share that with us? Okay. Have you ever referred anyone for a cochlear implant? Have a show of hands if you've referred someone for a cochlear implant? A couple? Okay, well, probably makes. Well, my next question, for those of you who have referred someone for an implant, was that something that you instigated with the patient, or was it a patient who came to you asking for an referral? I suspect a lot of the time it may be the patient asking you for a referral, or you've received a report from an audiologist suggesting a referral. And that's something that we want to try and change. I want to tell you about my first referral of a patient for a cochlear implant. It was about 25 years ago when I was working in a hearing aid clinic with severely and profoundly deaf adults. I met Mr. Smith, no relation to me. He was in his late 70s and he had a severe hearing loss in both ears. And he was getting by with his hearing aids, just. And then he lost the hearing completely in one ear and was no longer receiving benefit from a hearing aid in that ear. And he was really, really struggling. He was withdrawing socially, not wanting to attend family functions. His family were very worried because his wife had a lot of health issues, and because Mr. Smith wasn't able to hear well, there was a real struggle with her care and how they were getting information from doctors about her. So he was seeing an ear, nose and throat specialist about some other issues, and I wrote to the ENT, who was not a cochlear audiologist time, and suggested that he be referred for a cochlear implant candidacy evaluation. The ENT told Mr. Smith that cochlear implants were primitive and that he should go back and get a hearing aid for his dead, completely non-hearing nose. That was quite distressing for Mr. Smith. We talked about that for a long time. He went. Thankfully, he had a fantastic GP, and he went down to his GP, and his GP made a referral to another ear, nose and throat specialist who was working in Cochrane. Mr. Smith went on to get a cochlear implant. It certainly wasn't a quick solution, it wasn't an easy pathway for him, but he did really well, and it was actually a life-changing thing for him. I saw him over the next 10 years until he passed away. And I kept seeing him for his hearing aids when he was attending the implant for his cochlear. And he would tell me the things that he'd been able to hear thanks to his cochlear implant. Being able to hear his granddaughter say, "I do," at her wedding, being able to hear his great-grandchild's voice, and importantly, being able to care for his wife as her dementia increased and to be able to continue living independently because he was able to hear well enough to do so. And I think, to me, part of that story highlights the role of the GP. You can be real gatekeepers for people being able to access cochlear implants and to provide appropriate referrals. And I'm just so glad that Ms. GP that gate open to him. So what is a cochlear implant and what does it do? I have a very brief video animation here just to give a broad strokes overview of a cochlear implant. So let's see
how a cochlear implant works. Sounds are picked up by the sound processor, which sits behind the ear. These sounds are turned into digital code, which is then sent to the implant just under the skin. The implant converts the code into electrical signals and sends them down to the electrode array. The electrode array is fitted in the person's cochlear. When the signals get to the array, they stimulate the nerve fibre, and the signals are recognized by the brain as signals.
That's a simplification of quite an amazing device, but it highlights a couple of important things there. It's quite surprising to me the number of people who come in to talk to me about cochlear implants who don't actually realise that there are two components: an internal component, the actual cochlear implant itself, and the external sound processor or speech processor. So when we say cochlear implant, we're really shorthand for both. So in this picture here, you can see one of the cochlear's behind the ear processors with part behind the ear and then a magnet and transmitting coil sitting above and behind the ear. More recently, we have available some off-the-ear processors, which are very popular with our recipients as well, where everything's contained in the one component behind the ear. That type of processor is not suitable for everybody, but as part of our candidacy evaluation, we're talking with our recipients about the different types of sound processors, how they differ, the advantages and disadvantages, and we're spending a lot of time talking to them about how cochlear implants work and what to expect. And James will tell you more about that afterwards. So, who would benefit from a cochlear implant? Now, if you're looking at your handouts, just stop here for a minute, please. Don't turn the page any further for a moment. So in Australia, it's estimated that over 150,000 people have severe to profound hearing loss in both ears. So they're people who would potentially benefit from a cochlear implant. 2 out of 3 of those people are over the age of 65. Now, that's not really surprising when we know that hearing loss incidence increases with age. And as we have an ageing population in Australia, the number of people who are likely to be eligible for cochlear implants is growing. And we need to make sure the message is out there so that people can access it. Now, in this area, in North Sydney, estimated about 2,800 people in 2018 had a bilateral severe to profound hearing loss. What percentage of those people who could have a cochlear implant, who meet the criteria for cochlear implant, actually have one? Throw me a number.
5%.
5%? Any other takers? In this area, it's estimated only 10%. So it's a pretty low number. But compared to the rest of the world, we are actually doing quite well in that. I believe in Australia generally, the percentage is a little bit lower, more around 8%. And that's in adults. Thankfully, the story is different for children. With our newborn hearing screening, where children with hearing loss are picked up at birth or close to, and with our early intervention programs, the rate of implantation for children who need one is much higher, up in the 90% or higher. Now, I want to talk a little bit about the evidence for cochlear implants and referring to some consensus statements that were released in 2020. So 31 experts in the field of cochlear implants from around the world reviewed the available evidence and published these statements about cochlear implants. They're broken broadly into 7 categories about awareness of cochlear implants, clinical practice, the effectiveness of implants, factors associated with COVID implantation, quite a few statements about the relationship between hearing loss, depression, cognition, and dementia, and some cost implications. Now, I'm not going to go through all of the statements tonight, but there are some that are quite relevant and set the scene to the rest of what we're talking about. First of all, awareness of cochlear implants among primary hearing healthcare providers is inadequate. So people are under-identified as being a candidate for a cochlear implant. That's among GPs. It's also among audiologists. So there are referral pathways and guidelines and an understanding of how that works can certainly help increase access to cochlear implants. And really, that's what we're working on here right now. When we're assessing candidacy, we're looking at people's best aided speech recognition. So we look at how they go with hearing aids. James is going to talk more about this later, but it's not just about just face-to-face communication, the big picture of what you see, but how they actually go understanding monosyllabic words in sentence tests. And there is room to improve or to standardise some of the tests that are used and how they are used. But one of the things that James will be talking about is some 60-60 guidelines, which is a guideline that you can use when thinking about whether or not somebody may be a candidate for a cochlear implant candidacy evaluation. The evidence is there that cochlear implants significantly improve speech recognition in both quiet and moderate noise in adults, and that these gains in speech understanding remain stable over time. And I think you'll hear that better when we hear our recipients talk afterwards. Another piece from the evidence is adults who are eligible for cochlear implants should receive implant as soon as possible to maximise their speech understanding. It's not to say that people who've been deaf for a very long time won't benefit from a cochlear implant, but the sooner we can implant them, the better the recognition, the better their speech understanding is going to be, and the easier the pathway. So adults with hearing loss can be substantially affected by social isolation, loneliness, depression. And that's because if you can't hear, it's hard to connect and communicate with people. And the evidence suggests that treatment with cochlear implants can lead to significant improvement in these areas of wellbeing and mental health. Now, there's more and more longitudinal studies underway, and that will give us more and more evidence. I'm not going to spend too much time on this. We could spend weeks talking about the association between age-related hearing loss and cognitive and memory impairment. But we can say that the use of cochlear implants may improve cognition in older adults. By that, we're still gathering, I guess, enough evidence to say the same for hearing aids, but certainly early intervention with hearing improvements more likelihood is leading to improvements longer term in terms of cognitive function. So, sorry, not an improvement in cognitive function, but less decline in cognitive function. And an important statement that age alone should not be a limiting factor to cochlear implant candidacy. And that's important when we go back to the beginning and think about the fact that hearing loss is more common as people age. And age alone is not a barrier to cochlear implantation. Other health factors considered. I think my oldest cochlear implant recipient is 90. So far, what the statements we're really talking about was for people with severe to profound hearing loss in both ears. And that was because they really international consensus statements, and access to cochlear implants in other parts of the world is not as good as it's here in Australia. We're in a very fortunate position with the way funding works here, that for people with single-sided deafness, that's hearing loss in one ear, that we will also consider a cochlear implant. So we look at each ear individually, and cochlear implants have been shown to benefit patients with single-sided deafness with improvements in quality of life, improvements in speech understanding, reduction of tinnitus in the ear that's been implanted, and improvements in localization of sound. So really, we want to make best use of each ear. So for some people, that may be normal hearing in one ear, cochlear implant in the other ear. It may be 2 cochlear implants. It may be a hearing aid in one ear and a cochlear implant in the other ear. And that advice has certainly changed since I first started working with anything to do with cochlear implants, because originally it was thought that you wouldn't be able to integrate the sound from a hearing aid with the sound from a cochlear implant. But we know now that we want to really make the best use of both ears, and there are a lot of advantages in bimodal hearing and pronouncing. So that's enough for me for now. So I'm going to hand over to my colleague James, who's going to talk more about things.
People that I see, I get the impression that a cochlear implant is perceived as a last resort, something for someone who has no hearing left at all. But if this really were the case, criteria for when a person needs a cochlear implant would be very simple. You just have to be completely deaf. And that may be how things were in the 1990s, and it's certainly how it was presented to me in the 1990s. But it's definitely not true that you need to be totally deaf to get a cochlear implant. It's definitely not the case. So, at what point is a cochlear implant going to be better than a hearing aid? I think that is the key concern regarding assessment. So introducing the 60-62. The key indicators for referring a cochlear implant candidacy assessment are difficulty in communicating with others, even when they're wearing their hearing aids. Someone with hearing thresholds of equal to or worse than average hearing loss of 60 decibels. Speech understanding, which is equal to or worse than 60% when they're wearing their hearing aid. And this can be true in one ear or both ears, for one or more of these conditions. The 60-60, the second and third of these 3 criteria, were developed by researchers in the University of Michigan who looked at over 500 people with cochlear implants who had been successfully implanted. And they looked back at their preoperative scores for speech and for hearing, and they found that 95% of them met one or both of those criteria. That is, they had hearing that was worse than 60 decibels, or they had speech that was equal to or less than 60%. So let's unpack the criteria. The difficulty communicating with others, even when they're wearing their hearing aids. Well, everybody has some degree of difficulty at certain times. But when someone is routinely struggling, particularly when they're on the phone and they don't have access to lip reading cues, or when they're speaking to someone with whom they're not familiar, they don't have access to familiarity with vocal cues, or if they're often needing other people to repeat themselves, it's very likely that at the absolute least, their hearing aid function should be reviewed. And when that's done, in the context of a cochlear implant assessment, it can be seen whether a cochlear implant actually would perform better than a hearing aid. As a side note, I should mention, I think that quite often when you're in a clinical setting, people aren't that, they're quite reluctant to ask you to repeat themselves more than once. So sometimes when you're the doctor or the audiologist, you need to watch for other clues that someone might not be hearing so well. For instance, if they're frequently looking at a significant other who they might have brought along to help them do their hearing. A false red flag suggesting significant communication difference. It's when people start withdrawing from social events that they've enjoyed. And quite often the people themselves don't see the connection with their hearing, and they just think, oh, well, I'm not enjoying it so much anymore. But quite often it's because they're actually not hearing other people, and so they're going to events and feeling quite isolated socially. So let's consider the second of the alerting criterion, the 60 decibel hearing loss or worse. 60 decibels is approximately the level that most people speak at. So if you've got someone who has a 60 decibel hearing loss, they're not going to hear you easily without hearing aids, unless you speak very, very loudly right up near their ear. 60 decibel hearing loss looks something like this. This is a completely artificial audiogram with all the X's and the O's, the left ear and the right ear, pretty much in the middle of the graph. So I think the relevance of looking at something like this is if you are seeing an audiogram where a lot of the X's and the O's, the hearing thresholds are in the lower half of the graph, very likely that that person already meets one of the three criteria cochlear implant assessment. Here's a more realistic example. And while the person with this hearing is certainly not likely to be a cochlear implant candidate in their better ear, the right ear with the red marks, they quite possibly are in their left ear, the blue marks at the bottom of the graph. And that person may actually appear to hear quite well, particularly if you're talking in a quiet room and face to face. But if you're on their bad side, on their left side, or if there's a bit of noise, or if they're trying to tell where sound is coming from, it's going to be much more difficult for them. And someone with this kind of hearing is actually doing pretty much all their hearing with one ear only. And a cochlear implant can still function to their other ear. Brings us to the third of the three criteria. When someone's wearing their hearing aids, their speech understanding is equal to or worse than 60%. And the key here is they have to be wearing their hearing aids. And that seems pretty obvious, but at its heart, a cochlear implant assessment is working out whether someone will do better with a cochlear implant or whether they're doing just fine with a non-surgical option. Here's a pre-operative audiogram for Sandy, who in theory should have been easily, very well hearing aided. However, in her case, hearing aids didn't help very much because her speech understanding was at best around about 50%. So looking at that audiogram, you would never on the face of it think, oh, they need a cochlear implant. But Sandy found hearing aids tended to turn quiet mumbling into loud mumbling. She now has 2 cochlear implants and she loves them. When she got her second cochlear implant, she said to me, it felt like the gremlins had finally left her ears, and she couldn't believe that it was possible to hear so clearly. my favourite image of her is of her listening to audio version of George Eliot's Little March while doing her gardening, streaming it directly to both her cochlear implants, something that would have been completely impossible to her. Worth taking a breath at this stage and reminding ourselves that at this point, a referral for a cochlear implant assessment of someone who meets one or more of these criteria, just that, just a referral for an assessment. The cochlear implant assessment might indicate that a person would do better with a cochlear implant, but it might not. And if someone isn't a cochlear implant candidate immediately, it's quite possible that their hearing might change. And if it does, and they become a cochlear implant candidate, they'll be in a much better position for having had the assessment already. And at the very least, part of the cochlear implant candidacy assessment involves optimising their hearing aids, so they'll be hearing really well. Most people I see for a cochlear implant assessment are actually cochlear implant candidates. But it can take a very long time, sometimes years, between the first time someone suggests a cochlear implant to someone and the point that they actually have an assessment, and then the point that they have their surgery. So it's so important to mention the word early. What happens when someone is referred for a cochlear implant assessment? They embark on the journey. Their first appointment might be with either an audiologist in a cochlear implant clinic or with a cochlear implant ear, nose and throat specialist. And generally, it doesn't really matter which one is first, although if someone doesn't have private health insurance, they would probably do well seeing an ENT first, because the ENT can sort out some of the funding. Once it's been found that someone is a suitable candidate and they are going to get the cochlear implant, surgery date is arranged, and after surgery, they return to an audiology clinic for their cochlear implant switch on and ongoing care. Nicholas will speak more about what happens in the ENT consultation, which includes evaluation of the temporal bone and the auditory nerve, stimulus function assessment, discussing surgery risks, and other surgical consideration. A candidacy assessment is usually spread over a number of appointments and can take 2 to 3 hours or more than that. During the appointments, the cochlear implant audiologist will discuss a patient's history in detail, look at their lifestyle, and their perceived difficulties, and their life experiences. The audiologist will test their hearing and speech discrimination in detail, and test their hearing aids, and check that they're doing everything they can do. They'll evaluate tinnitus and also get the patient's own perception of their tinnitus and of their hearing. Set goals and review realistic expectations. They'll spend quite a long time pulling out cochlear implant dummies, different manufacturers, and looking at how it works and what the person can expect to get from the cochlear implant. And also look at how the cochlear implant will be funded. In Australia, it's unlikely that someone who is suitable for a cochlear implant will be unable to get one, which is the cost. 4 key funding options. Some private health insurance, hospital cover, public funding, eligible veterans, Veterans Affairs will provide the funding, and self-funding. The patient has a private health insurance hospital cover that covers hearing implantable devices. The cochlear system, both the implanted part and the processor should be fully covered. If the patient does not have private health insurance, they may be eligible for state government funding. And as of last year, this is now an option at Royal North Shore Hospital. Switch on or activation is exciting and challenging at the same time. The initial sound of a cochlear implant can be very strange. Ongoing adjustment is fairly intensive early on, and usually quite quickly the sound stops sounding strange. But there is some time where a patient needs to practice and attend appointments, and the audiology clinic will support them with, particularly in the first few months, very frequent appointments. And it is wonderful when people around the person with hearing loss can support them, not just the audiology clinic, and particularly when they're embarking on a cochlear implant journey. This can involve just asking how people are going with their hearing, how they're feeling about their hearing aids, and providing a referral to an ENT and cochlear implant audiology clinic. And it's also great when the referral has plenty of relevant information. And it's also great to regularly keep in mind the 3 key referral triggers, particularly the 66. Those are communication difficulties in daily interactions, poor hearing, and poor speech and understanding. I think this slide is in some format in your. So now, let's move from Maryland.
Thank you, everyone who's joining us from home. Probably might meetings. But we really appreciate you, Wendy, organising this for us. And on behalf of Nicholas and I, really, implant surgeons at Royal North Shore Hospital, and we also work here at North Shore Private, we'd like to welcome you all. Like James and Annette, I'm more interested in the second half of this, which is hearing from 4 of our patients. Just because we sort of do the implants and we do the surgery, but it's really James and Annette that have the fun time with our patients because they develop a really close relationship that we don't as surgeons, and so they get to see them through their journey. But this brief talk is really just to give you an idea, all as potential clients, audiologists, and general practitioners that might refer patients, what the actual surgery involves. And this is, I acknowledge mytech.com, we helped them develop this cochlear implant form for our otolaryngology surgeons that do cochlear implant surgery. And it's a very nice cartoon of what the implant involves. And I think James and I already highlighted what it is. But the surgery that you're about to see, you'll see a very brief one, really demonstrates how we put the receiver stimulator under the skin. And then the actual speech processing is the bit that changes and improves in time. So over the time span of which a patient has a cochlear implant in, the bit that's under the skin doesn't really change. And that's the bit that Nicholas and I put in. So that's what you'll be seeing. The typical operation for a patient under 65 these days, at least for myself, is a day surgery procedure. If the patient's over 65, often there'll be some vestibular dysfunction. Sometimes there'll be some carer issues at home, and we'll often keep the patient overnight. But frequently, probably over 70% of the time, there won't be a lot of impact, and they'll be able to go on quite easily the next day. For both Nicholas and I, the surgical time, the actual technical time is between 1 and 2 hours. So this is what we would consider a small to medium procedure. It's certainly not like something where we remove vestibular schwannomas and the patient stays in intensive care for a night and then spends 5 to 7 days in hospital. It's nothing like that. And this other infographic that you can see from NITEC demonstrates and builds on what Annette showed you, where the receiver stimulator is under the skin and the external processor is outside. But you can see the electrode extending down into the middle ear, which is what the video will show you. And the actual electrode gets gently inserted into the cochlea. And then we let everything settle down for 2 to 4 weeks. And the actual switch on, the fun bit, James and Annette do like a sort of a month later. And so this is a video of preparation from yesterday, and it just demonstrates what it looks like in the operating room for the patient. That's one of our scrub nurses, Simon. But you can see we prepare the ear, and it's all in a sterile fashion. There's a facial nerve monitor on the patient because one of the complications and one of the target zones is to drill between the facial nerve and the nerve of taste, the porta tympani. You can see we prepare where we put the implant in under the skin, and the incision varies somewhere between 3 centimeters for children up to 5 to 6 centimeters for adults. And it's in the post-auricular incision, and within a few weeks, often the hair has grown over that, and we would expect not a lot of scarring to occur in that region. This is a cochlear implantation of a 19-year-old boy who had a motor vehicle accident, suffered a temporal bone fracture. So axial scans are demonstrating a fracture through the cochlea that you can see right here. So this patient was essentially anacoustic or had completely lost their hearing on the left-hand side and was suffering from severe tinnitus. So this was the indication for the surgery. This is a left ear, very similar to the setup you just saw. And this is the mastoid bone that you can feel behind your ear, the hard bone that we drill through to access the back part of the middle ear. So this is a high-speed burr that sort of spins 75,000 reps a minute. And we drill through all of this bone. Some of the landmarks we're looking for is the back wall of the ear canal. We sometimes follow the middle cranial fossa floor, and then we also isolate the jugular bulb at the back end of the mastoid bulb. We then drill, it's currently recommended to have a little bit of a seat in which the cochlear implant can sit in, but that may change as the years come on. But this tries to prevent slippage of the implant anteriorly. So we use what we call a pan feature on a stick here to measure the depth and identify where the actual implant's going to sit in. And we spend some time drilling that seat, some 10 minutes or so. And then you'll see here a dummy steel version of the actual cochlear implant that I'm putting into place to ensure that it's in the right position posteriorly so that everything's ready for the electrodes to dip in. You can see the sigmoid sinus here, the canal wall here, the middle fossa, middle cranial fossa at the back here. Then we get a very small, between 1.5 to 2 millimeter drill, and we try and identify the facial nerve back here and the nerve of taste from the porta tympani. Now, in this patient, he was unusual because when you get a temporal bone fracture, you can sometimes heal with bone. So he had a neo-osteogenesis where the cochlear opening should be. So at this point, I put an endoscope in just so that you can understand the relevant anatomy. And you can see here the malleus here, the first bone of the hearing, and the second and third bone of the hearing. And there should be a black hole here, but you can see the bone filling that opening. So we continue to drill through that fracture line in the cochlea until we get an opening. And that's where we almost get to this region here. Now there's a potential space in which we can thread the cochlear electrode, which measures between 0.4 and 0.8 millimeters, depending on the manufacturer. Here's the cochlear implant we're putting in from Cochlear. And you can see now we've pre-sized the drill space, and so that should just sit in position nicely. This is the ground electrode that sits underneath the muscle of the root of the zygoma. And you can see this plastic sheet that we take off, where we try not to touch the actual electrode at all. And the objective is to insert the electrode over about 90 to 120 seconds, very slowly, and into the cochlear. And then we pack around that to stop any fluid leaking from the inner ear. You can see we put the electrode in, and then that's some of the muscle from the patient that we pack around. Once we do all of that, we end up closing the wound. So we put some packing in over the electrode so that it doesn't escape. And then we close the wound in a few layers, typically. And then after we've done that, the next step is actually, this is with the wound closed, this is the patient from yesterday. And then we actually perform this procedure called neural response telemetry, which is where we, after we've taken all the bandages off and dressed the area, sometimes you can do it while the bandages are still on. We actually electrically test the integrity of the implant. So we look at the impedances and whether the implant's in the right spot, and then also whether there's current being delivered in the appropriate manner to the cochlear nerve. And that's what this neural response telemetry does. And that takes about 4 minutes or so to do after the patient. And then once that's all intact, then we wake the patient up. And usually this sort of procedure, the patient goes home, typically, like I told you, day surgery under 65. So our patient yesterday, who was 49 years of age, single-sided deafness, that's her 1.5 hours after the surgery. She was leaving at 2 hours post-operation. We do expect in about a quarter of our patients for them to have a fair bit of nausea and vomiting and some imbalance. So sometimes they need to stay for longer. And as I mentioned, occasionally the patients will stay overnight, particularly if they're over 65. But it is something that to consider that this is really not something that is typically an overnight operation for a younger patient. Usually about a week off work for the patient and 3 to 4 weeks off heavy exercise. And as I mentioned to you, about 2 to 4 weeks post-surgery, once all the swelling has settled down over the implant, that's when we can apply the external processor and then James do the switch on. In terms of complications, this is all aggregated meta-analysis data, but the major ones we talk to patients about is non-function of the cochlear implant. And this is usually a very important part of our preoperative counselling. We need to set expectations very appropriately for patients. They're not going to have natural hearing immediately, but over time, with work with James and Annette and with reprogramming and often with software off the iPhone with the newer models, the patients learn to use the implant, and we can expect a patient to have explantation for non-use to be less than 1%, and explantation or removal of the cochlear implant for infection to be quite low. Facial nerve injury and taste changes in units that do a lot of this surgery are usually below 1% for permanent change. We really do try to preserve those two nerves when we do the surgery. So in summary, the operation is typically what we would call a small to medium operation, short stay surgery, typically with minimal pain and very low mobility, but it would be very interesting to hear what Steve, Greg, Samadi, and Rose thought of the operation as well. So we didn't want to take too much time up, Nicholas and I, so I'll pass it on to Nicholas now, who will give us a few tips on what general practitioners can look at in terms of around the time of the surgery. So I'll pass it to Nicholas.
Thanks, Wendy, for inviting me to speak here tonight. Just switch presentations across to you.
We should be able to get it from the desktop.
So what I wanted to do is very briefly cover in this talk the important things that as GPs you might need to know before and after cochlear implant surgery in patients you're going to see.
Sorry.
All right, hopefully that works for you. Yeah. The important things to know both before and after cochlear implant surgery. So, Norman briefly touched on this at the end of this talk. Infection is one of the key risks that we try to mitigate around the time of surgery. We do that both before the operation with vaccinations and then afterwards with the use of antibiotics. The risk of bacterial meningitis is much higher in cochlear implant patients, and that also applies to patients that have compromised shunts, other factors that we'll see on the next slide as well. With cochlear implants specifically, it was first noticed around 20 years ago where there was a manufacturer, US Advanced Bionics, that had a type of cochlear implant with a positioner on it, and there was a lot of the patients that around that time were having bacterial meningitis following cochlear implant, particularly soon afterwards. And it was at that time there was an initial recall done of that type of implant, and since that time the rates of bacterial meningitis have been much lower. But it was from that that vaccine guidelines for cochlear implants came out. So these are the Australian recommendations that kind of match a lot of the international ones as well. And so what we're looking for is under this category here, which is in the highest risk category of cochlear implants. Essentially, the guidelines are to have both a Pneumovax and a Prevnar vaccine. So the Prevnar 13 being 13 BCG vaccine and 23 BCG vaccine. The guidelines, I'm not sure of the exact immunology behind this, are to give the 13-valent one, the Prevnar 13 first, and then 2 months later, the 23-valent one, the Pneumovax 3. And then for every 5 years, if the patient knows at this stage, they need to continue to get a 23-valent booster. If the patient happens to receive the 23 valent one first, then you need to wait at least 12 months after that one before giving the 13 valent one. In terms of why the timings are what they are, I'm not sure of the exact science behind that, but that's kind of guidelines currently. So prevention by having the vaccination before the operation is important. However, after the operation, we use antibiotics to help to prevent infections. This is one situation where when you have an ear infection, this is not a watch and wait approach afterwards. If someone has had a cochlear implant and they have an infection in and around the ear, they need to be managed with antibiotics. Generally speaking, there needs to be a low threshold for using intravenous antibiotics in admission to hospital, particularly early on after a cochlear implant, because there hasn't been enough time for the seal that no one's shown you putting around that muscle packing around implant as it goes into the cochlea for that to develop and seal off completely. But essentially, if someone is very fresh after having a cochlear implant, or if they've got some malformations, and potentially if there's evidence of early meningitis or mastocytosis spread, then have a low threshold for an intravenous antibiotic therapy. No one also touched on vestibular complications, and studies suggest that there's around 4% rate of vestibular complications, but this is likely higher for transient vestibular issues afterwards. Essentially, you're putting an implant into the cochlea, which is very close to your balance organ, so inherently the balance organs are going to get a little bit affected as well. This is more prevalent in older patients. It's also at a much higher rate if the patient has a second cochlear implant because they don't have their other side to compensate for it as well. And so it's important when we're putting in a first cochlear implant to do a check of the patient's vestibular system, which will help to determine, particularly when it comes down to a bit of a line fall in someone with bilateral hearing loss, which side you implant first. Sometimes a check of their vestibular system beforehand will help you to determine which is the better side to implant first up. Essentially, most of the vestibular complications are very transient and can be improved upon with both time and vestibular physiotherapy. The risk of damage to the facial nerve itself is very rare in surgery with the techniques that we use, and Snell showed you with the monitoring that we use on the patient during the operation. And that allows us to passively monitor if we're getting very close to the facial nerve. There's a bead from the machine to warn us of that. And it also allows us to actively monitor if we're in an area that we're unsure of the anatomy, or we want to check whether something we think is a facial nerve is a facial nerve, we can actively stimulate it to confirm it. It is common for postoperative weakness to occur, and I guess you might be seeing patients potentially soon after the operation where they may develop a delay into facial weakness, and that can occur due to either swelling or inflammation, and it can occur due to reactivation of a herpes virus as well. And so if you're seeing that soon after the operation, obviously if you can get in touch with us as surgeons, that would be very helpful. But the important thing is to commence treatment with steroids, strong anti-inflammatory to essentially settle that inflammation and restore facial nerve function as quickly as possible. It is also possible when a cochlear implant is switched on for the first time that some of the electrodes may be, this may be stimulating the facial nerve, because the facial nerve does lie in very close proximity to the implant. However, it is possible with the cochlear implants to switch off electrodes until you find the ones that are causing the stimulation of the facial nerve, and then prevent that from continuing to occur. Skin issues. So when you put a cochlear implant in, you are placing it underneath the skin, and the external processor is attached onto the skin with a magnet that connects through to the internal processor. Essentially, the skin thickness is important, because if your skin is too thick, then the magnet won't attach very well, the implant might fall off, and if your skin is too thin, the risk is that you can have ulceration through the skin and exposure of the implant. So it's a very fine line between having skin that's at the right size. The bigger issue is generally that the skin is too thick, so we do take steps to measure the skin thickness both before the operation and during the operation. Sometimes skin underneath it needs to be thinned during the operation or after the operation to allow for optimal magnet attraction and communication of the processes. What you can sometimes see, particularly if the magnet strength is a bit too much, especially in the early postoperative period and soon after the switch on and the implant is attached on the outside, is that there can be some irritation, some pain to the skin over the area. So if you start to see something like this under the area where the magnet is attaching onto, then usually discontinuing temporarily, considering a short course of oral antibiotics, and then a review with radiologists, teaching us magnet strength or adjust magnet strength as well as include. And then we also touched on taste. The chorda tympani nerve, essentially when we're putting in a cochlear implant, we're tunneling the electrode through into the cochlea in between the facial bone and the chorda tympani with the nerve of taste. So it's quite common for a patient to have some effect on their taste afterwards. This is not just with cochlear implant surgery, this is all with surgery, because annoyingly the chorda tympani nerve decides to run right through the middle of ear space, and so it's commonly affected in one of our operations. It's also a much more sensitive nerve than the facial nerve. And if we're tunneling a cochlear implant in and we need to make the tunnel wide enough to be able to get the implant in, we're always erring on the side of pushing a little bit more onto the chorda tympani nerve, facial nerve, because the key is to preserve the facial nerve, because that has the greater effect on external prosthesis. The good news is that chorda tympani is only about a quarter of taste, because there's another nerve which supplies the posterior part of the tongue on the same side, and there's obviously your other side to consider as well. And so despite that initial effect, most patients do have a good recovery of their taste, even if there's an initial effect. And it can resolve as early as 3 weeks afterwards. The longest I've ever seen it last after surgery is about 6 to 12 months. So it does resolve, it's just a question of how long. And finally, just to finish up, cochlear implantation is a safe, reliable, and well-tolerated option for those who receive limited benefit from traditional hearing aid implantation. The risk of serious or permanent complications related to surgery is low, and tried to cover some of the more common ones. And hopefully it's either all fairly manageable, and particularly with the way we approach the operation, planning the into the operation beforehand, thankfully all very low chance of occurring. Thank you very much.
Yeah, the next one. Thanks, Mark.
Thank you, Nicholas. We're going to invite our patients to come to the front now. We have 4 patients who've kindly given up several hours of their day for us, and I've got a line of questions drawn up by James and Annette to ask them. So we'll ask Rose if you can join us out the front, Rose. You can come. We've got 4 chairs. Yeah, I think so. Rose, Steve, Greg, Samadhi, you can come up. Yeah, thank you. When I call you, that's Greg. This is Samadhi and Rose and Steve. And they very, very kindly gave their time for us this evening, just to give us a bit of a better understanding about the important, very important point that Annette made about how when you lose your hearing, you lose your contact with people. And so this part of the body is a very unusual and unique part that, of course, those of us that work in that area will love. But I personally, like Annette, feel it's very important because it's so much a part of who we are as people and how we communicate with people. So I think it's quite important for us to understand as clinicians the impacts of what we're doing and also the good and the bad. So we'll start. We've got a microphone that we'll pass around. So I might start with you, Greg, actually. So we've got a mic over here. Yep.
Just tap it. We can.
So Greg, can you tell us first of all when you started to experience your hearing loss?
So I first started experiencing hearing loss in about 2000. I found my first audiogram just recently, and my hearing loss then progressed over the next 15 years slowly, and I worked my way through low power hearing aids, finally up to high power hearing aids. And eventually my hearing fell off a cliff. It was a very, very small cliff at that stage, and it was time to think about cochlear implants. Nim will stop me when I talk.
Yeah, I was going to ask, when you were struggling with your hearing, how did it sort of make you feel in terms of when you were working and in a social setting?
Yes, so pretty awful a lot of the time, right? You're there, you're doing your job, you're a competent person, but you're not able to communicate with people either easily or reliably. And so that's frustrating. It's frustrating for you. It's frustrating for the people around you as well, and your family in particular, because they're the ones that that benefit or suffer all the time. And it can also be exhausting because you're putting so much effort into just trying to hear something, and then how much effort is left to try and do something sensible with what you've heard. So that's maybe sounds a little bit dramatic. It's not like that all the time, but there are times where you would get to the end of the day and you are just exhausted and depressed, and thought there must be an easier way.
One of the things that patients often mention to us, and I'm sure Nicholas, there's a lot of cognitive fatigue that occurs with hearing loss, because patients are using multiple modes to gain the communication they want to gain. And so being tired and frustrated and irritable at the end of the day in someone who's deaf is quite a common complaint. So then what sort of led you on the path towards thinking about a cochlear implant? Like, how did you come to hear about it? Can you tell us a little bit about that?
So my mum was a bilateral recipient, and there's apparently no connection between that and my condition, but so that meant I had some awareness, and my path was a little bit unusual. I'm an engineer and I'd worked in the telecommunication industry. I decided to go back to uni and study cochlear implants while I had hearing aids. And so partway through this process, I received bilateral implants. And so I understood the theory side of it. And now I was learning the practical side of it, which was an amazing journey. There's only a small number of people in the world that have done the sort of research I was doing and had that experience. So it's really an amazing journey to go on. What was, but even though I was a really well-informed person, I still didn't want to rush into a cochlear implant. I had one of my supervisors was from Cochlear. I need to say, by the way, I'm a Cochlear employee, but I'm speaking here as a recipient, not on behalf of the company. And the second part normally says, consult your clinician for hearing issues. I think that part's probably clear here tonight. Yeah, so you have to go through the decision, should I get an implant? There's uncertainty about the outcome. There's surgery. There's, I guess they were the two for me, uncertainty and surgery. What did I want to do? And so I took a little while to think about it. The point that's been made about the speed of implantation is really important. So you want to keep the stimulation of the auditory nerve going. So long periods of deafness are not a good precondition for a good outcome. But in the end, it only took a few months. And I was fortunate as well, the clinic I was going through dealt with hearing aids as well as CIs, so cochlear implants. So it was a matter of my audiometrist saying, you know, I think you need to go and see the person in the next room. And so that was a very smooth transition for me.
And can you tell us, Greg, just about the operation itself, the experience, pain, dizziness, just what it was like for you? Because we often do these things to patients, but we don't hear exactly what it's like.
Yeah, the was pretty straightforward. Nimal saw me smiling when he said it's relatively pain-free. But when you see the tools being used to lift the flesh off the bone, you indeed end up with a headache. But I was home that day. I had a headache for a few days, not that much pain relief, and was working within 2 or 3 days. So no dizziness for me. So the mileage may vary. It's different from person to person. But I had a very smooth recovery. I'm a bilateral recipient. They're done 12 months apart, and for that's quite common in adults. For kids, they might be done at the same time, but for adults, it's a risk management approach. So you have some hearing on one side, you have an implant, you might have a fantastic outcome or not. You've still got the hearing you had on the other one. Mine were 12 months apart.
And what about the switch on, Greg? What was that like? Tell us like that day, what it's like to sort of have this sort of electrical device turn on and start to hear again. And what was the hearing like? What's the hearing like now? Can you compare the two?
So
your emotions?
The first thing that was done was that the individual electrodes are stimulated, and I heard 22 different tones quite clearly, and they sounded like quite pure tones, which surprised me a little bit. And having established some levels, so the audiologist goes through a procedure to set a threshold level and a maximum comfort level, where you can just hear something and where you go, that's enough. Then the microphones were turned on, and all of a sudden you hear all this sound. What was interesting, it was really audible. So I wasn't struggling to hear something, but it was easy to hear something. I couldn't understand anything to start off with, but within a couple of minutes for me, I was able to perceive a cadence of sound. I was able to differentiate ling sounds, if you know them, so I could tell the difference between sh and s. Neither of them sounded like sh and s, but I could tell they were different. Then within a few minutes, I could hear a tinny voice. This was pretty amazing. And my wife came along with me, and the audiologist so invited me to bring someone. And one of the reasons there was to have the person whose voice you're most familiar with speaking, so you've got the most chance of understanding something. So it was pretty amazing. Lots of things sounded like running water to start off with. Audibility was fantastic. You'd hear things, but and I could see someone clicking a mouse. I had a mouse clicking for 10 years, but I could see it, so I knew what it was. For those of you that have little kids or have seen little kids where they're a few months old and they're lying on the mat with big round eyes looking around and discovering the world, that was me. So you could hear all these things, but you don't know what they are. I was post-lingually deafened, so I'd heard before. So I was able to join the dots when I could see things. But I also drove my wife to distraction saying, what was that? What was that? And I found out lots of things were called. I've told you 3 times already. So it took some time. It took a lot of support. When I spoke to Nirmal, he said, you know, my job's an easy one. The hard work will come with the audiologist and with your family. And
if you could compare the quality of sound just from what you remember it in the first hour or two to what does it feel like now? Can you describe what the hearing is now?
So sound was, they say it's robotic, it's pretty tinny initially. Now it's just normal for me. So for people whose voices I knew before I lost my hearing, they sound much like they did before. But that's because the brain's amazing, right? So the brain's doing this work, it's joining the dots for me. For other voices and sounds, they sound normal to me, but what's normal? It's different to your normal, okay? To me, it sounds like a voice. I can tell the difference between male and female, between different people speaking. Accents can be a bit challenging for me to try and pick an accent, but also for new voices. If I meet someone that has not even a new person, it can take me a little while to get used to that. If they have a particular accent, that can take me a little while to get used to, just as I learned to understand the sounds. And that's with 5 years and 4 years practice.
So thank you. Just one last question. What are your thoughts about when you got referred or when you started to think about the cochlear market? Now, thinking about what you've experienced now, do you think you would have preferred to have it earlier, or are you happy with the timing of it? Or because you have an unusual situation because you're close to mum's an experienced bilateral user.
So I went through a phase with high-power hearing aids, and the range of loud to soft in the world, which is called the dynamic range, is enormous. So it's 120 dB or something. With high-powered hearing aids, by the time you're at that level, you've got this tiny amount of hearing left, and so everything is squashed into that little range. And for me, the difference between inaudible and painfully loud or distorted is tiny. And so the high-powered hearing aids weren't a success for me. And that was a 2 or 3 year experience. In retrospect, if there'd been a way to bypass that, that might have been a good outcome for me. There are all sorts of complexities to that question, right? But that's what I think about when I think about timing.
Oh, thank you. Thank you very much. We might get Sir Ali's opinion now. One of the important points that Greg mentioned was pain and discomfort with loud sounds. One of the functions of the cochlea is to fine-tune the auditory spectrum. And when you have dysfunction in the cochlea, you can have an all or nothing phenomenon with sound. And sometimes when the sound's loud enough, there's actual discomfort with people who have hearing loss. And a lot of patients describe pain And I think that's a little bit like what Greg was alluding to, where there was a compression of the sound, the whole sound world into a short dynamic range, and then discomfort when it got really loud. Mrs. Triley, thank you very much for giving us your time. Can you tell us a little bit about your hearing loss journey? When did you first start to notice you were losing your hearing? How did it come about? Can you give us a bit of a background?
Yes, something about 1996, and the first time few people were talking about, I'm not hearing from time, they're calling and I'm not listening. And also I experienced a kind of fullness in the ear. So at the time I went to the doctor and they recommended, they checked, they did the audiologist, and he suggested there is a possibility of using a hearing aid. We tried, and he said, sorry, we don't have any solution for your problem. That was way back in 96.
Did you try hearing aids at that time in Singapore?
Yeah, he just tried a hearing aid in the air. And he said, probably, because I'm hearing other noises more than actual voice. And he suggested, we have no solution for you. Please, you may need to live with it. That was way back 96.
And so how did that impact you? Like, were you working at the time? Were you having trouble at work or at home?
Yeah, quite an amount of challenge in the work environment, especially when I'm speaking to people face to face, no issue. But when there is in a large meeting room, people talking about, and especially listening from the newer voices, is really, really challenging. In those days, the technologies were poor, but in some companies, we have the digital telephony at least better. And I used to manage large computer centers, and some of my computers used to make beep, some alert. I couldn't recognize. So some of my operations team saying, oh, Sarathi, you are not seeing this. So this kind of challenges I've seen, and embarrassingly, sometimes they may say something we guess and talk about. That's even my wife still now complains.
Charlie's wife, for those who is sitting in the back here. Was it frustrating at home? Did you get any clues at home with people making comments at home about your hearing?
Yes, they didn't make much comment.
So when did you start? When did you first hear about cochlear implants then?
I came back about after coming to Australia about 2006. We have seen quite an amount of problems, and I approached my GP. Then he initially suggested to go to ENT specialist, then audiologist, and then we tried a hearing aid. We tried for a month, but what I'm hearing is the plastic sound and all the keychain sounds more than the voice or anything. And listening to the mobile phone is completely disruptive, because something is in the ear and the phone sound, it is not even picking up at all. So I told the audiologist, I'm not really benefiting anyway. So then my GP, Dr. Bala, and he realized maybe you are a candidate, you must see Dr. Nirmal Patel. That's where he sent me about 2011.
And tell us about the decision making for the cochlear implant. Did it take you a while to come to that decision? It's obviously a big step potentially for patients with thinking about surgery. Tell us about that decision making and your discussion with your family. Was it a long process or?
Yeah, it's a bit of a hesitant on my side, feeling like going to the operation table and something get operated, something get inserted. That's a kind of initial reservation was there. So, but we have seen it's the other implant not working. It's your quality of life, social interaction, everywhere it's impacting. So then I thought, okay, let me try it out. And Dr. Nirmal Patel gave me a lot of assurance, and especially Northside Audiology, they assured it will be good and your levels will improve and all. So all of their help, including my GP and audiologist and the ENT surgeon, all this made me confident to go to the operation. And I've seen that benefit today.
Can you tell us about your switch on then? What was the sound like when you first heard sound through the implant?
Yeah. Way back in the 80s, we used to hear one song, probably many of you know, We Are the Robots kind of songs. So at that time, is the AI robot part is coming, the Star Wars movie came. So when it really is turned on, it was something like that. The voice, you feel it's an electronic sound. But it didn't take much time. Within 2 to 3 weeks, slowly I used to see the natural balance between both left and right ear. So not much time it took, I believe.
So it initially sounded more robotic, and then over time the sound becomes more smooth. So if you were to compare what you were hearing like, say, in the early 90s, not easy to remember, but to now, can you compare the two to us at all? Does it sound different? It's difficult to remember, I guess. But can you,
Now
yeah, what's your type of hearing sound like now compared to when the switch on occurred and even before that? Do you feel it's a comfortable hearing?
Yeah, no problem at all.
Yeah.
Yeah.
And you mentioned that you feel like there has been some benefit. Can you give us, as the audience, a clue in your work life and at home, what sort of benefits you might be getting if you were comparing it to when you were using your hearing aids?
Yes, practically, like say, taking out, we can experience next to me, somebody speaking, sometimes we are not able to understand what they're actually asking or talking about. So now the situation has totally changed. I teach at the university and I have a large class. Sometimes I have a blended audience where we have people sitting in front and people are remote. I'm able to manage all that conversation well, thanks to everything from Cochlear all the way to all my medical professionals. This is fantastic, I would say.
It helped a lot with your work too. Well, thank you very much. We might give the mic to Rose.
Right.
Rose, well,
Oh,
as you can tell, Rose doesn't need to grab the mic. Rose is also one of our long-standing patients. And Rose, maybe you can tell us, just when did you first start to notice you were losing your hearing? Was it something you noticed or something?
Currently, when I was a kid, I was partly deaf, but I didn't know. And I didn't find out until 1970. And I had pistons put in this ear. One piston didn't work, second piston didn't work, and the doctor didn't want to touch it. And he said, "Can I go in again?" I said, "Yes, you can go in again." So we did another piston. And then I started to wear a hearing aid in this ear. Now I can't think when it was now. But I've had skin grafts, I've had a lot of things done to it. And the last operation, how long ago was it before I don't know. But yeah, so I yes,
What sort of challenges were you facing with your hearing, Rose? When it wasn't working?
finding it hard to get and communicate with people, you know? And so I found it a lot hard, and I just more or less kept to myself, you know, because I couldn't hear other people, so I kept to myself. And yeah, so yeah.
Well, as you may guess, Rose is pretty gregarious and social, so it would have had a significant impact on her life. So then, tell us about your journey to get a cochlear implant. Did you see your GP and they?
No, I think after the last operation, I'd either you said it or someone else told me.
Okay. Maybe.
About cheese.
Okay. And can you tell us about your journey with the surgery? What was that like? Because right
No after effects.
no, we didn't think that
It was very, very good operation.
it wasn't supposed
And people couldn't kill.
no, it wasn't supposed to be like that. Because it's sort of maybe I was bullying a little bit, but she's Rosa's over 80. She did actually do spectacularly well with the surgery. Tell us, Rosa, did you get much dizziness afterwards?
No, not any business.
Any pain or
No,
pain
no,
or anything?
no.
No? Well, can you tell us about the switch on day? So Greg and Sravi have told us, but when you had the implant switched on, what was the hearing like when it first came on for you?
It was like a hissing sound at first, like, you know, it was a bit strange. And I got used to it, you know, so, but yeah, so.
So if you were to compare your hearing now to what you might remember before, does it sound reasonably natural to you? Or is it still?
Yes, it sounds natural to me, yes.
Okay. And can you tell us a bit about how that's impacted you after the implant? Do you find you're able to more easily go out and socialise?
More able to go out and when you're movies and all that sort of thing. I didn't go before, because it's all sort of stepping and stuff like that. Yeah, so I was happy about that. Yeah.
Very nice. And what are your thoughts? Do you think this is sort of a technology that maybe you wish you accessed a bit earlier?
Yes, I wish I had it. So it's a wonderful technology, you know, just how it works and, you know, sort of things inside and the magnet and sort of stuff like that. Yeah.
Oh, thank you, Rose, for the overly generous comments. But, Steve's unique in the patient population because Steve has one normal ear. So he is single-sided deafness. You remember Annette mentioned to you earlier on in the talk that we're trying to treat each ear individually. So your patients that have a normal ear on one side, and then, for example, come in with sudden sensory neural hearing loss related to perhaps a infection, and then they have the usual treatment of oral steroids, and that doesn't seem to work. And then sometimes, if they're the right candidates, you may refer them to an ENT who might offer intratympanic steroids. And those sort of patients, if they're not rescued by steroids or orally or intratympanically, they can now become a cochlear implant candidate. It's not the first step. The first step is, of course, to look at other types of hearing assisted devices like a cross-aid and sometimes even what we call a bone-anchored implant. But Steve went through that journey. So Steve's interesting in terms of the type of hearing loss. Maybe, Steve, you can tell us about your story with hearing loss and your journey.
Yeah, it'd be interesting to see if I get it right compared to your experience. I think I first realised that there was something wrong around about February of 2014, and I remember that because, very precisely, because I'd been to a concert in the Hunter Valley, and I just, for days afterwards, had ringing in my ears, and I just thought something's gone wrong here. But then, even I then had to go overseas.
Who was it, by the way, Steve?
It was Hunters and Collectors. And when I had to go overseas for work, and I was in the hotel room, and I just kept hearing this sort of pumping in my ear, and for a long time I just thought there's something wrong with the air conditioning here. There's a pump going on in the wall. But then I realised it was following me everywhere I went. I walked around town and I still heard this sound. And then so that's when I sort of realised there's something funny with my ear. I came back to Australia, went to see my GP, and he just took some wax out of it and said, there you go, you'll be right. But I realised pretty quickly that that hadn't helped anything in turn at all. And so then I went back to the GP who referred me to the audiologist, and they did some tests and realised that I was actually had very poor hearing in that one ear. So the sort of symptoms for me were just difficulty in understanding conversations when there's any kind of background noise.
And it didn't happen like that. It happened over weeks to months.
Yeah,
Yeah.
yeah. So in retrospect, I thinking about it now, I've probably had this problem for years and years, and I've always had struggled understanding, participating in meaningful conversations when there's a lot of noise around, the pub or dinner party or whatever. But then this process with the audiologist, so the first step was just to try putting in a hearing aid, and going back sort of regularly for testing, and they sort of realised that my hearing was steadily deteriorating until it got to the point where I think they realised the hearing aid was not going to work. There's something going on in there, some kind of pathology that was actually happening as they watched. And so I think the process was that they recommended, provided a report that went to my GP, who then and it recommended that I have a referral to you. And as I understand the process, then you sent, as I remember it, you sent me off some MRI scans and diagnosed a benign tumour in my ear, a schwannoma, I think, is that what it's called? And so it's an interesting thing, because I remember you said to me, I'm probably not going to die of this, but it said if you go and if you want to get it removed fairly soon, and I can do it, maybe you. If I wait too much longer, then it'll have to be a brain surgeon that does it. And I thought, okay, well, that's the first thing. Let's get this little benign tumour removed. And then you said, by the way, since we're doing that, you might want to consider a cochlear implant, because it'd be a reasonably convenient thing to do. But I think you also warned me that because of this type of surgery and the problem I had, very low expectation that the cochlear implant would actually help much, I think.
Yeah, I guess you're probably allowing me to speak a little bit about your case, which is unusual. And the time of that discussion happened over 3.5 years. So we scanned Steve's ears sequentially over many years, and he had a small benign growth in his cochlea that was growing away from the cochlea. Away towards the apex of the cochlea and away from the base of the cochlea. And if it started to grow towards the base of the cochlea, then it may reach the base of the cochlea and start to go into what's called the internal auditory canal, which shares the fluid systems with the brain lining and the nerves that travel in the internal auditory canal. And then it's sort of a combined procedure where we do appendicitis operations with neurosurgeons. And so it's an unusual indication, but his tumour was growing bigger and bigger, and as you recall, Steve, you were getting a lot of ringing too.
Yeah.
And so there was some work being done early in the 2000s in Germany. They were doing the pilot work where in single-sided deafness patients, particularly with unilateral tinnitus that was disabling, they would put a cochlear implant in as a tinnitus suppression device after we tried the hearing aid, after we tried meditation, all the cognitive behavioural therapy, all these things. And they found about 90% of the patients got significant reduction of their tinnitus when they switched the cochlear implant on. And coincidentally, at the same time, they found that their speech scores improved substantially on that side. And that was the beginnings of some of this single-sided deafness work that we did. And so actually, Cochlear came out to Steve's operation because we took the tumour out, and then we had to cut half of the cochlear out, or about a third of it out, to get the tumour out, of course. And then we put the cochlear implant and then repaired it with a bit of his own tissue. And no one was at that stage, Cochlear was teaching Nicholas and myself, these soft surgery techniques to preserve hearing and be very delicate with the structures, and introduce the cochlear implant very slowly over like a minute and a half. And here we're just cutting the whole thing open, ripping it apart and taking the tumour out and then putting an implant in. So it's the exact opposite of soft surgery. And he did spectacularly well. I think his speech understanding and speech scores went a little bit like the video showed you, but got up to the 90% within a few months, I think. So he's a very unusual case and has done spectacularly well. And I promise you, we didn't load the patient audience this way. It wasn't supposed to be like that. But he did do. They generally do quite well, patients. But Steve's unusual because he had his cochlea completely opened up, and a cochlear implant put in, and then we repaired the cochlea, and the tumour was removed. And so what was your experience with the switch on then? Because it's quite different to the other three patients in that they had this slowly enclosing deaf world, whereas Steve was hearing quite normally on one side, but struggled in noisy situations, which is classic for patients that have high frequency hearing loss, but also unilateral hearing loss. And they also can't identify the direction of sound. So can you tell us what it was like when you got the switch on? Because you would have like maybe mechanical and then natural. Can you tell us about that?
Yeah, that's right. Well, the first thing was it's quite a funny experience because there's kind of a cast of thousands in the room from Cochlear and everyone wanting to see if this procedure had actually worked. So when the switch on came and I reacted in a way that meant I must have heard something there from sort of cheering and clapping, like sort of like landing on the moon for there sort of thing. Whereas I was kind of underwhelmed because it was just this funny mechanical sort of robotic sound in my ear, and as Nemal says, I can still hear perfectly well my other ear. So yeah, essentially, but I did hear the way these the other three panels have described the sound is pretty much the same way that it's
So like mechanical,
it's very mechanical and
robotic.
It was not able to actually, it wasn't just amplifying words, it wasn't like you could clearly understand speech or anything. And I've always thought of it as sort of like trying to learn a totally different language, like, you know, Chinese or something it's just not language as I understand it, but somehow the brain works out how to sort of decode these sounds and interpret them.
And can you remember over what time frame you actually started to interpret words? Like in people that were familiar to you and then maybe people who were unfamiliar to you in a different hearing setting? Difficult hearing setting.
Yeah, fairly quickly, I think, like over a period of just weeks. So I was using this pretty neat little app on my phone to sort of train myself that the audiologists set up for me, which was kind of a fun thing to do anyway. So I assume that probably helped a lot. Yeah. But I reckon it's fairly quick that I noticed myself that it was providing an improvement, and certainly in social situations where previously I would have to sit there a little bit, like Rose was saying, I would sort of withdraw a bit from conversations at dinner parties or whatever, because I just couldn't understand people. And now I was finding I was participating kind of more normally and not actually even realising it was the implant that's helping until afterwards when I'd get home and think, hey, wait a minute, I've had a pretty good sort of evening, chatting away with these people, which I wouldn't have been able to do a few months ago. So it's kind of been I guess less sort of, it's just something that's kind of seeped into my system.
Yeah, so sort of less of a wow factor.
Yeah,
but would you say, if you compare the before and after, that there's a little bit more ease in the hearing or less discomfort when you're going to social environment, like just less tension about going to social environment?
Definitely less tension. I mean, I had been sort of just not going to certain things.
Yeah.
But also, one thing I forgot about, you mentioned it earlier, and that is the having the implant and using the Cochlear system just eradicated the tinnitus effect. And if I don't wear it for some time, so working a lot from home at the moment, I don't have to wear it, I don't really need it, so I can hear people about 1 ear and there's nothing people I'm talking to, but the sort of the noise in that side of my head, which just sounds like a forest full of crickets, sort of gets louder and louder and louder, and then I'll put the Cochlear on and it sort of goes away again. So it's quite good from that point of view.
Yeah. Thank you for that. I mean, was the operation for you, because it was a little bit different, was it a different experience? Can you tell us if you get a lot of pain with it? Did you get a lot of dizziness or taste or painful nerve?
Yeah, so I think my recollection is I did stay overnight, but I went home the next day. I think you did. Yeah, we opened that. We thought you'd be quite dizzy. Yeah, and I was really dizzy. Yeah, really. I mean, I don't know if it's unusually bad or not, but it was terrible. Just
because he had that tumor, we expected it, and because we opened the whole cochlear apart, we thought he'd be a lot dizzier than the average patient.
Yeah, so it was shocking. I just felt like incredibly bad case of seasickness. It was just slight movement, and I just wanted to throw up every time.
And was it weeks to get over that dizziness?
I think probably like a week and a half. It wasn't that long, you know. And I don't actually remember much pain. Yeah, I know I was given some pretty strong painkillers in case, and I forget which one it was. One of them actually made me feel even worse in terms of nausea, so I just stopped using it. It wasn't so much a pain issue anyway, it's this dizziness.
Yeah, it's quite an interesting operation because you make that post-tracheal cut and you denervate a lot of the area, the soft tissue there. But then the bone that you're drilling through is insensate. So it's not a super painful procedure. It's not as painful as you might expect.
Yeah, pain wasn't the thing.
Yeah. Well, thank you. We really appreciate all your opinions. Did any of you have any sort of last comments to make?
Yeah. So thanks, Neville. A couple of things, just some observations. So you've seen the four of us up here listening and doing really well, okay, if we say so ourselves. But something that James and Annette will have noticed that maybe you guys noticed or not is that most of us turn to look at the speaker. So even though we're understanding really well, we're also looking for other cues, and that takes effort and concentration. These are high-class problems, right? Because we're understanding the conversation. How good is that? But the research and the manufacturers don't talk about restoring hearing. They talk about restoring a sense of hearing. And there were discussions about expectations. The expectation discussion is really important because these are some great outcomes, but they're not all this great. And it isn't like it was before. It's different. But you can understand speech and sometimes really, really well. Music, not so much. 3 points to close. Something that I just thought about when I had my switch on. I was at home doing something and my wife said something behind me. And I hadn't heard her say something behind me for years. And it wasn't impolite, but she said something and I turned around and we looked at each other and it was just this look of shock that this had happened. So I'm an engineer, it's all maths and physics, but it's an amazing thing. It's really, really important that candidates have information, and information can be hard to come by. So thank you very much for coming along tonight and being interested, because there's not a lot of information out there, not a lot of knowledge in GPs with hearing loss and cochlear implants. So I just wanted to say thank you very much. I'm sure Neil's going to say the same, but as a person involved in the business and a hearing researcher, that's fantastic. So really, really appreciate it. And if you can tell your colleagues, thank you. Thank you.
Thank you very much.
I've got a question here. The question is, music not so good. What do you mean by that?
So I'm here as a recipient, not working for Cochlear, okay? Sorry, I'm here as a recipient, not a Cochlear employee. So if you think about the cochlea, so it's tonotop, it detects frequencies at different points along the cochlea. There are about 10,000 hair cells that sense frequencies and some others that moderate frequencies. The cochlear implant from Cochlear has 22 electrodes, different manufacturers, different numbers. So imagine that you could sense 22 different frequencies. Well, normal hearing people can sense maybe 20,000. So the ability to accurately perceive frequencies is decreased. Now you'll see studies that talk a lot about frequency discrimination. So to detect the difference between frequencies is one thing, and that's important for speech and inflection, tonal languages. So discrimination can be quite good, but the accurate perception of frequency differences is problematic. I can talk at length about it. But when you talk to recipients, they'll often say, oh, I enjoy music. And you can say, well, physiologically, that's really hard to understand. And if you talk a little bit more, they might say, oh, not the way I used to, but I still enjoy it. And that's the thing in the end. It doesn't matter if it's the way it was before. The question is, are you enjoying it? Are you getting something out of it? So it's different. And each of us might give a slightly different answer to that question, but it can still be enjoyable.
I just want to add one point when you said it may be useful for the GPs where one of the difficulty I encountered is like say even I'm feeling that there is a loss of hearing. One of the challenge to accept that there is I was able to hear very well in my mother tongue. So the conversation in the mother tongue or the audio that I listen are perfect. But when it comes to English, it's very, very challenging. So maybe sometimes some patients, they may have coming from different cultural backgrounds and language backgrounds. That's probably they need to recognize. So currently, no audiologist test is possible in any other language other than English, right? So natural language, there are mother tongue issues are slightly different with somehow with English or other language. Probably that's something to be accounted for in future research.
Thanks, that reminds me of one more thing, and then Mel will take, Emma will take the microphone off me. But cultural aspects can be really important as well. I have a colleague who is in her late 30s, and she's from Iran, and she has an implant on one side. She said to me, I've never told my sisters that I have hearing difficulty. My mother knows, but my sisters don't. And so she was quite comfortable talking to me about it, but she was absolutely uncomfortable talking about it in her own culture. It was perceived, well, however it was perceived, she didn't want to do it. So there are cultural influences there as well. There are different sorts of implants. You say, I've got behind the ear, and some of the other guys have off the ear. In some cultures, the off the ear is much more preferred because it's less visible. The sign of disability is something that people don't want to have. Anyway, so now someone take the microphone off.
Yeah, all of them points really appreciate it. Thank you very much. Oh.
How do you hear your own voice?
Was the question, how does my own voice sound?
Yes.
Switch it on. When they switch on.
So how does it sound? It sounds different to before, but it's the voice I've been listening to for a number of years. So your brain joins the dots and it probably sounds much the same. At a more technical level, there's no bone conduction hearing happening, which is how we hear a lot of our own voice. But for me anyway, there is no bone conduction. So it's different, but your brain does this amazing thing that it's your voice.
Where is the magnet? I can see the magnet on Steve. Right? Other people don't see that.
Yeah, we all do different places. So you can see just here. Yeah. The coil is about 3 centimeters across. The magnet's less than a centimeter, and it just holds this part on. So you can let it go. The skin thickness there is 8 millimeters.
It varies. And there are various standards for different type of implants according to skin thickness, and sometimes as Nicholas mentioned, you can thin the skin, things like that. But yeah, usually you need to have less than 10 millimeters to get a good connection. Well, I'd like to really thank our formulation. Oh, one question. Lovely.
A question for Rose. Rose, you sound like you've always had some hearing loss.
Yes, apparently I had hearing loss when I was born. Okay, so I don't know what happened. My mastoids only developed on the halfway, and they didn't develop properly, and therefore I had a hearing problem. And I was going to school, and I didn't realise until about 30. And then what happened? Every time I lay down, I had to put my glasses on. And that's where we found out that, there was a hearing problem somewhere. Yes.
Do you think that the cochlear implant has made your hearing better than it ever was before?
It's very good, very good. Yes, yes. It's, just can't bear it out, It's magnificent, it's a wonderful, what do you call it? Unconventional, So yeah. So that's what happened. My mastoids didn't develop, and I had a lot of hearing problems, which I don't know. But how I found out was the one named Dr. Gillen, and every time I lay down, I'm all dizzy and stuff. So I had to have my glasses, the bed and everything. And that's when I found out the hearing, or I had something to do with the hearing. And that's 1970 I found out. And all those years I've gone around deaf, half deaf, really. Yeah.
So, but patients can complain of tinnitus. You can't help with the tinnitus, the real tinnitus.
If for tinnitus, it's quite a broad, complicated topic, but simplistically, if they're deaf enough to consider a cochlear implant, so if they meet the criteria that James spoke about and they cross the thresholds radiologically and the medical fitness, in other words, if they're a cochlear implant candidate for hearing loss with ringing in the ears, usually the implant will improve the ringing, because often the ringing is related to the damage in the hair cells related to the cause of the hearing loss. In other words, the hearing loss and the tinnitus are linked there. You can sometimes have patients that have tinnitus but normal hearing, and there are some people that call that sort of brain tinnitus. But in the patients the patient population we're talking about, when they're deaf enough, then yes, it should help. It would have around somewhere between 70 and 90% chance of improving the tinnitus. A little bit like what Steve was talking about. When you put the device on, the ringing settles down, you take it off, the ringing comes back.
After a patient with unilateral deafness and tinnitus with mitochondrial disease, will that help? Anything help her?
Possibly. I mean, she might be a candidate to start the single-sided deafness conversation. So that begins usually either with someone like Nicholas or myself, or to James Burnett. And we would do all of the appropriate radiology testing. But if there wasn't anything that was causing, that we could easily see that was causing unilateral hearing loss that was related to cochlear dysfunction, then they may start with something like what's called a contralateral routing of sound device, a version of a hearing aid where you wear two types of hearing aids, one in the normal and one in the bad, and transfers the sound by Bluetooth. Or you try a bone-anchored implant trial. And if they don't like both of those, that's when you start talking about single-sided deafness cochlear implant journey. So it is a bit of a journey, but it's as James mentioned, the patients with single-sided deafness also begin a journey. It doesn't always end with a cochlear implant, but it might.
Ask Steve about listening to music. Can you distinguish between a string or a woodwind?
So the question for those online is, can I distinguish between different types of sound, string, woodwind, and so on? So yes, I can. Percussion's fantastic. Cymbals and drums are just excellent. So everyone can give a different answer here, but yes, I can perceive the difference. I can perceive rhythm well. I don't perceive harmonies well. Harmonies are discordant because I have difficulty with accurate perception of the frequency ratios. And when I was first switched on, I asked about music, and the advice from James' colleague was look for something with a strong rhythm and lyrics. Cochlear implants are designed to give good speech perception, and that was good advice to me. Music that I knew before I was a much bigger answer than your question, sorry, before I lost my hearing sounds much the same, but that's my brain doing that. Really complex music. I had the amazing privilege to hear Mozart's Requiem played at Mont Saint-Michel in Normandy. If anyone knows it, fantastic soloists, orchestra, choir, just amazing. It's just a wall of sound. I can't understand it anymore. So it's fantastic I have that memory, but that's something that and everyone might be different, I can't do anymore. That's a shame, but there's lots I can do.
Well, thank you very much. We might wind it up now. Just on James and Ed have a small token of thank you gift for patients who very kindly gave us the time. So thank you again for the time. We thank you for your time. And James and Ed have a small thank you gift for our patients.